received no questions from the public in advance of the meeting. We have one member signed up and potentially others, and I'm delighted that we will have members of our mirror board with us as well today. Let's look first at our conflicts of interest. Are there any new conflicts or conflicts relevant to today's agenda? I'm looking across the board and I cannot see any. Thank you. The minutes of our last meeting, which was held on the 19th of March. Comments or amendments? I will take those as accurate. And anything arising that is not already on our agenda? No. Thank you very much, everybody. I'm going to pass now then to our Chief Executive, Fiona Edwards. Over to you, Fiona.
Hi, morning, everyone. Clearly, this week is a really significant, sad week with the publication of the national inquiry into contaminated blood yesterday, and I think it's really important that we as a board note the work that we are doing with regard, and Sarah will refer to it in her quality update, regarding learning and really reflecting on the appalling tragedies for tens of thousands of people as a result of a failure of care and taking a real listening and safe approach for people over many, many years. My initial reflections are particularly around the messages of the inquiry chair regarding the culture of the National Health Service, public service and government, and the need for a reset, the complexity of how we're organised and the regulatory environment in which we're organised within, that makes it very difficult for people that wish to raise concerns as patients and families to know where to go to get a quick response. And also, I'm really reflecting on our work as a Frimley system, and how this inquiry report reinforces the importance we attach to creating an inclusive, open environment for all our staff, connected with partners and increasingly with residents, so that people feel safe to speak up and challenge where they feel things aren't right. Creating a safety culture and a safety-focused culture relies on leadership that is prepared to hear difficult stuff and to respond, and in a way that is thoughtful and supportive to help all parties change and improve, and also deal with the concerns swiftly as they are raised. So I haven't yet read the report fully in detail. I've listened to some of the transmission, but certainly we will be doing some significant amount of work, and also both to encourage people who may not have come forward yet to check who've had blood transfusions since and during that time, and may have received contaminated blood. So it's really important that we, in our communications, encourage people to know where to go if they have not done so before. So that's a really important for us to think about, that all of our work, we're in the finalising our financial plans and our performance plans, needs to be set in the context of doing the right thing for the people we serve and creating the best environment possible for people to be able to do their best work together for that. And we ended the year in a reasonable performance position as an integrated care board last year. So we start the year with significant challenge as we continue our recovery across primary care, across the urgent emergency care space, and on elective planned care. But the signs are good as we start into the year for being able to both continue the improvement of our operational performance as an NHS system, but also to really move forward with priorities and our strategy as framed by our Integrated Care Partnership Assembly focus. So I think I'll stop there here.
Thank you very much, Fiona. And really good way to move to our first agenda item on the new hospital programme update, which presents an enormous opportunity for the health and well-being of all residents across the Frimley system and beyond. So over to you, Sam.
Yeah, thank you very much, Priya, and thank you, Sam Branscombe, for presenting the slides for us this morning. For those who don't know me, I'm Sam Burrows. I'm the Chief Transformation, Delivery and Digital Officer for NHS Frimley. And I'm just going to give you some brief headlines on where we are with the new hospital programme and the planned new hospital for Frimley Park. So next slide, please, Sam. So Frimley Park Hospital is one facility that's currently operated by Frimley Health NHS Foundation Trust. It's one of 10 sites that trust has some involvement, oversight or delivery of services from, which encompasses and provides a base for 13,000 staff who work across the trust, serving a local population of approximately 900,000 people who access an array of services provided by FHFT. Taken together, the value of these services exceeds £1 billion in total cost of delivery. So really, really significant organisation and supplier of health and care to the local population. Next slide, please. Now, the current Frimley Park Hospital, as marked on the map on this slide by the blue star, which is in the Frimley town area, south of Camberley and north of Farnborough, was built in the 1970s, primarily from a material called reinforced autoclaved aerated concrete, or for the rest of this presentation, I'll refer to it purely as RAC. RAC is a building material that was commonly used across a number of infrastructure projects during that time, and is present in a number of facilities up and down the country. Next slide, please. The construction of the Frimley Park Hospital site is actually dominated by the use of RAC. 64% of the current facility has some presence of this particular type of concrete. And you can see it marked on the map here on the right-hand side, which shows the current site and where there is a significant presence of RAC in the current estate. That clearly is significant for the facility and is the primary method of construction for that particular hospital. It's not viable in the long term to continue using RAC-based concrete in buildings, and there is a requirement on the NHS for safety reasons to stop using buildings made of RAC by the year of 2030. Next slide, please. So whilst the hospital is owned and operated by Frimley Health Foundation Trust, the vision for a new hospital is a system partnership endeavour. It represents the importance of the hospital as a community asset and stretches actually beyond the NHS. So in terms of planning for delivery of operation of the new hospital, we'll be working in partnership with local government, with Health Watch, with the voluntary sector and with local people to ensure that what is planned for the new hospital meets local people's needs and can really fulfil what is a critically important role as a building which meets the needs of the local community more broadly, not just in the delivery of healthcare services. Next slide, please. And at its heart, for the delivery of healthcare and clinical services, this is a huge opportunity for clinical transformation. So the opportunity that the provision and build of a new hospital gives us is to take the chance, which is potentially once in a generation, to transform the array of services, not just those that are delivered inside the hospital estate, but also outside as well. This is a chance to really deliver what's core to our ICS strategy, which is developed around the principle of service integration, ensuring that all the planning we're doing for the delivery of our clinical services takes account of the holistic needs of people and the array of providers right across the public sector and beyond who have to work together in order to meet local people's needs. So in the planning of the delivery of this new facility, we'll be working in partnership, delivering that strategy together to ensure that primary care, community care, secondary care and beyond are really working in harmony to ensure that our transformation plans for clinical services are supported by the delivery of the new hospital at Frimley Park. Next slide, please. So already we have a good idea of what our local design requirements would be, and this is a broad framing of the need for the new hospital. So we're expecting a much larger facility than the current hospital at Frimley Park. That's just due to some of the design requirements of new hospitals under either building standards or national policy. For example, most of the care provided to patients in beds in the new hospital will be done in beds in single rooms rather than on ward-based care. And when taken together, some of those requirements really require the much larger footprint for the delivery of those services. The budget for the build exceeds £1 billion. It's a really significant investment in local services. Again, once in a generation opportunity to bring some really significant national funding into the local population that we serve. And because of the presence of RAC in the Frimley Park Hospital current site, we also know that it needs to be open for 2030, so it can act as a suitable replacement for the services we currently provide. We're expecting more beds in the facility, supported by both community and virtual care as well, which I think speaks to the importance of that strategy that I was just mentioning. But as well as our local design requirements, it's supported by a whole suite of national assumptions under a national programme known as Hospital 2.0. So Frimley Park is not the only new hospital that is being built in England currently. It's part of a much broader programme, which is flagship national policy, and to ensure that there's a degree of consistency and value for money for the taxpayer, there is a national approach to ensure that we have modern methods of construction, international best practice played in, some flexibility in how the facilities are designed, and some common design requirements for all of these projects to ensure that we are taking advantage nationally of the economies of scale that should be available. And as you'd expect, given current overarching policy, we are working towards a net zero target by 2040 for the NHS, and this new hospital will be a key contributor of that. Also, the use of digital AI and other clinical and non-clinical technological interventions will be a core part of this as well. And you can see the complementary nature, therefore, of the national work that's ongoing in this space and our own locally defined need. Next slide, please. So clearly, right at the core of all of this work is the importance of speaking and listening with local people to understand what local need looks like and the views of people who live in the local area. So already some early engagement has been undertaken. More than 3,000 responses were received online through the online portal, as well as 5 public listening events, 8 community engagement events, and then 2 events with all staff and broader stakeholders as well. So already a significant degree of local intelligence has been heard and is playing into the delivery of this programme. Next slide, please. The outputs of that engagement have now been written up through the production of an independent report, which summarises the views, the opinions and the feedback that were heard from local people, staff and partners during that time. If you want to read that report and get into the detail of it and find out more from what was heard and what was said during those events. You can find that report on the FHFT website. The exact address is at the bottom of your screen right now. And we'll ensure there's a link to that on the ICB website as well, so that attendees of this meeting can go and find out more should they be interested. Next slide, please. So in summary, moving to next steps, I have the next one, please. Clearly, there's a really important piece of work to do for a continued focus on the current site. We're expecting to use Frimley Park Hospital right the way up to 2030, and there is additional investment going into that site currently. We also have a critical responsibility to ensure the current building is safe, and there is work ongoing all year round to ensure that is the case. Clearly, that work comes with some degree of disruption to services, but where possible, our colleagues at FHFT work extremely hard to ensure that that disruption is reduced and that the ongoing remedial work that's required to keep the RAC areas safe is able to be done in a way which doesn't disrupt our services too badly. Next slide, please. We are also working in partnership between the ICB and FHFT to ensure that the potential new sites for the new hospital work keeps moving forward at pace, that due diligence is completed, and that we continue to engage with the public, our staff and broader stakeholders throughout all stages of the work which follows. The clinical transformation work, which I mentioned earlier, is well underway and ongoing, and will ensure that that keeps coming through both to this board and to broader areas later in the year. And given all of that work, we remain on track for the requirement for the build by 2030. Finally, the Joint Health Overview and Scrutiny Committee, which brought together local authority overview and scrutiny committees from across the geography, was established and met for the first time last Friday, which was a fantastic opportunity to hear the views of local people's democratically elected representatives, and the JOSC will meet throughout the life of the programme to ensure that the opportunity continues for both us and them to maintain that degree of conversation throughout. I think that's the last slide of the presentation, so I'll pause there. Thank you, and really happy to take questions from the board should you have any.
Thank you very much, Sam, and to all those who've been involved in getting us to this stage and beyond. Comments and questions from our board. And Caroline, as Chief Executive Interim at Frimley, would you like to add anything?
Thank you, Priya. I really don't think I can add anything. Sam did an excellent presentation and represented the discussion that we had at the Joint Health Overview and Scrutiny Committee, which was a really positive first meeting. So thank you for offering.
Thank you very much. Let's move then to our operational and financial planning section. And I'm handing over to Sam Burrows and Rich Chapman. Thank you both.
We're going to give Sam's voice a rest, and I'm going to cover this. Thank you, Chair. So could we move on to the next slide, if that's okay? Sorry, next one. That's it. Okay, so we're in the middle, reaching the end of the planning process for the 2024-25 financial year. And as an ICB and as a system, we are setting out to deliver a plan which balances in a very challenged environment the money and our objectives to deliver access to appropriate health and care services and our workforce, and improves our productivity, which in common with the NHS in England has not been improving as quickly since the start of, or the advent of, the pandemic. We submitted a plan to NHS England in line with requirements on the 2nd of May this year, and that plan is compliant in all of our access and performance criteria, but currently not compliant in terms of finance. And we are continuing to refine those plans, to develop those plans, with the objective of delivering a 2-year trajectory, which will bring the system back to financial sustainability, whilst also continuing to deliver for the population that we serve in the meantime. There are significant challenges within that plan, not least of which is the RAC situation at FHFT, which in and of itself, as Sam has described, contains a number of inherent inefficiencies. So as the hospital is required continually to close areas, to decant patients to other areas and move around, that creates bed pressures, it creates patient flow pressures through the hospital, which creates inefficiency in the system and has costs attached to it. And that's part of our discussion with NHS England. In terms of access and performance, we'll build on the fact that as a system, we delivered a 4-hour wait compliance of 76% throughout March, and we are aiming to improve that to 78% by March 2025. And that's no small achievement. It's certainly not the case that every system managed to deliver that 76%, and it was done through a combination of system working through integrated working together to ensure that we delivered that outcome. We have also reduced the numbers of patients waiting over 12 hours to between 5 and 6% at both of our acute sites. And we're predicting, and we are on plan to clear all 78-week and 65-week elective waits by September 2024. And the other real success story we've seen in performance is in our diagnostic waits, whereas at February, 86% of patients were waiting less than 6 weeks for diagnostics. And if we go back only as far as May 2023, that figure was below 45%. So real improvement there, and we are aiming to continue to drive that performance forward. We're forecasting some workforce growth in 2025, and as Sam referenced earlier, part of that is due to the opening of M Block on the Frimley Park site, which is those 72 new beds and diagnostic facility on the Frimley Park site, and also the Community Diagnostic Centre at Upton in Slough, with staff joining to deliver those services, which in turn will continue to drive an improvement in that diagnostic performance. And finally, there's been a lot of talk about productivity and the slippage in NHS productivity growth since the advent of the pandemic, and we're working in multiple ways on that. So Heatherwood Hospital is accredited by GIRFT. That's an NHS acronym. It means Get It Right First Time. And that enables us to drive productivity through Heatherwood, and we are actually planning to deliver significantly in excess of the national target of 107% of elective activity in the new financial year. Sorry, 107% of the elective activity that was delivered in 2019-20. We're now looking at and targeting delivering 119%, so 90% more elective activity this year than we delivered in 2019-20. At the same time, we are developing an allocative efficiency program, which will have 3 strands to it around early intervention and prevention for frequent users of acute services to enable those people to live healthier lives and reduce the demand that they place upon acute services. It has a strand around same-day emergency care, again, alleviating the pressure on our emergency departments to enable us to improve our 4 and 12-hour wait times. And there is an elective strand to that in terms of making sure that we are cognizant of and reacting appropriately to any unwarranted variation in the delivery of elective care in order to drive productivity. I'm going to stop there, Chair. I'm conscious of the time, and I'm happy to take any questions on what I've presented.
Thank you very much, Rich. Really clear. And comments and questions from the board, please? Ilona, please.
Thank you, Chair. Rich, you mentioned that we're compliant in terms of the national requirements on performance with this version of the plan, and I know we've seen various iterations, but not yet on the finances. Could you just explain the kind of process and steps involved in closing out the plan through to it being finalised?
Yeah, of course, Ilona. So we have a meeting with NHS England this afternoon. So after this meeting, some of us will be packing up and decanting to London for that meeting. That will progress, and it's not 100% clear how yet, but that will progress the approval of our plan. We are working to agree with NHS England that 2-year recovery trajectory to a financially sustainable position. So that's what we're looking for, and that's predicated on our continued improvement in productivity, particularly in the elective area, and the allocative efficiency work to ensure that we reach a financially sustainable position by March 2026.
Thank you.
Thank you very much. And any other comments or questions? Can't see any other hands up. Thank you. This has been a topic which has had a great deal of constant discussion. So thank you very much to all involved. Let's move then to our next agenda item, which is our clinical policies update. And our conversation is going to be led by Chief Medical Officer, Dr. Lalitha Iyer. Lalitha, I'll hand over to you.
Thank you, Chair. So the purpose of this paper and my presentation today is to update the board on the progress on the alignment project since this board approved it last year. First slide, please. Sam?
Sorry, I'm just doing it now. Beg your
Thank
pardon.
you. Thank you, no problem. So the idea behind the clinical policy alignment project was to achieve harmonization of evidence-based clinical commissioning policies across the Frimley ICB. Sam, if you keep going down, is the slide set after? It's the policy alignment? Yeah, thank you. So if you go to the next slide, please. Thank you. So at the moment, Frimley ICB utilizes 3 different suites of clinical policies according to where a patient lives based on the legacy CCG geography. And the reason this is important is that clinical policies set thresholds for referral for specialist services from primary to secondary care. It supports the funding for clinically effective and cost-effective care. So in order to do the best by the patients we serve, in April last year, this board agreed the proposal for the clinical policy alignment, its approach, its governance, and its timescale. So my presentation today in brief is just to update you on what has happened since then. So this is just a pictorial representation of the legacy CCGs and how they align to different policy committees. Next slide, please. So as I said, the aim was to reduce unwarranted variation within the ICB for access to care, ensuring that the commissioning was consistent across the entirety of NHS Frimley, maximize opportunities for us to invest in safe, clinical, and cost-effective treatments, and offer equitable access to care. Next slide, please. So what did we do so far? So we had a group of clinicians, primary and secondary care clinicians, some who are actually on the NICE board, for example. They went through each and every policy of the 56 policies that we speak about here with great diligence, looking at what is the clinical impact of these policies. Now, these 56 policies that have now been aligned and recommended for Frimley ICB for universal coverage are either those that were similar across the three legacy CCGs, or those that had very, very minimal differences, but had the header of the different policy committees. So it was decided that there is no significant clinical impact of the patient, and all these policies have been through our System Quality Committee for adoption. So largely, it was felt that implementation will represent an improvement in access and up-to-date evidence-based thresholds for treatment for the patient. So there's a tranche of policies that remain, that is the phase 5, where the differences and the potential high impact means that we are currently on a hold. Also because there's a joint Southeast Regional Priority Committee that's been formed. So Frimley at the moment is aligned to the Bob and Frimley Policy Committee. The last meeting of that policy committee is in fact in this month in May, after which we then become a unified Southeast Regional Priority Committee. And this committee has then decided to actually look at unifying the policies across the Southeast region rather than each ICB having a different set of policies. Next slide, please. So these policies are the new policies, those without any difference, without any clinical impact, may I add, those 56 policies will come into effect from the 1st of June for all new referrals. So the group was conscious that there are patients who may have been referred from primary care to secondary care, and they might be in the transitional phase. What we've therefore recommended is that a transitional implementation arrangement will be in place for these patients, with a principle of the patient not experiencing any disadvantage as a result of the new policy adoption. If the individual benefits from the new policy, that would be applied. If they benefit from the previous one, they would stay on the old policy. Next slide, please. So the comms teams from Frimley have been heavily involved with all the work right from the start. Clinical engagement has been ongoing, and there is a website that is live and linked from our Frimley Health and Care website, and patients and other stakeholders, any members of the public who want to contribute, can contribute with feedback in this engagement period, which started on the 3rd of May and runs until the 29th of May. The comments will then be reviewed, and the opportunity to act on it will be there before the 1st of June. I think this is my last slide. Is that right? Yeah, thank you. So I just want to take the time to also feedback from the Mirror Board. So I presented this to the Mirror Board, and I'll share my reflections. And I think there are two members, Linda and Samina, who are here as well to add anything I may have missed. So the Mirror Board agreed that this was an essential piece of work. They appreciated that a lot of work had gone into it and that there was no significant clinical impact. They did acknowledge that there was more to do and welcomed alignment across the region. They wanted to sense check that equality impact assessments had been done on each of these policies, and I shared with them the process and in Frimley and Bob Priority Committee, where there's a moral, ethical discussion, there's all perspectives considered before a policy is recommended for adoption. We also took an action to collate from anybody in the Mirror Board who was interested in enhancing the stakeholder feedback, and they would then be linked up with the comms teams for who else needs to be involved. I can see Ellie nodding here. She was really instrumental in helping us with all of this. I think at this point, I'll hand over to Linda and Samina in case you want to add anything. Thank you.
Hello. Hi, I'm Linda Gore. So I think we did discuss this, and it was great to hear that we're going to align the policies across. I think the impact on inequality would be great. So I think we were all agreeing on this. And then we touched on ensuring the stakeholder engagement, both internal and external. I can see we've seen that from Lolita's presentation, we've done all of that. And then we were just wondering, from a flexibility point of view, if the policies can be flexible enough to accommodate for future change. So just like kind of bulletproof, if you have to change policies or accommodate more diversity in the future, then your policies are flexible enough and open to do that. So that's what I had to add.
Yeah, thank you, Linda. Yeah, Mirror Board, really strong conversations and debate, and really welcomed Lolita's presentation. I think one of the actions taken away, and I'll be working on a smaller working group, is looking at equity in language, plain language, looking at options and inclusive communication so we can reach the communities that we want to reach. And so that was something that we will work on as the Mirror Board. But all of this that was presented was very welcomed and really needed to ensure we're supporting equalities. So thank you.
Thank you. Thank you both. Priya, I will hand over to you, Chair.
Thank you very much. Really good to have heard the work going into this. Comments and questions, please, from the board. Rachel first. Thank you.
Just a question about the discussion that may have been taking place with neighbouring systems. So I'm very conscious of the benefits of alignment within Frimley itself, but aware that the footprint of Frimley extends into counties on either side. And obviously I've got a particular interest in Surrey to understand what the conversation might have been with Heartlands about whether there is alignment or non-alignment between these decisions and those.
Thank you for that question. And that's exactly the reason why we've gone for regional alignment for priority committees. So when I say the Southeast Region Priority Committee kicks in after end of May, Surrey will also be part of that committee. There is a desire for everybody to have unified policies, because any change you make on any of the policies, it makes sense not to have the geographical variation within Frimley, of course, but as you say, exactly between the boundary of Surrey Heath and someone else living within Surrey or any other area that we have. So hopefully that will reduce a lot of work.
Thank you.
Thank you very much. Any other comments or questions? Huge thanks as well to our Mirror Board, and thank you to Linda and Samina for contributing to this presentation, this session today. Really helpful to have had that perspective as well. Thank you. Now I just want to check with Rich and with Tom. Rich, had I moved us on too fast? Had you completed?
Sorry, Priya, I'm off camera because my connection is struggling a little bit.
Don't worry at all.
To make contact. I'm happy to move on, conscious of the time.
Okay, fantastic. Thank you very much.
Thank you.
All right, let's move us to our standing items then. And we're going to go next to our board assurance framework with Caroline Corrigan. Thank you, Caroline.
Thank you, Priya. I'm hoping colleagues have had time to review the paper provided. So this updates our position in terms of the board assurance framework, particularly with regards to updating our strategic objectives. We've now pulled together those objectives against the board assurance framework and updated against the risk ratings. That's summarised in the cover paper. We continue to review this, and there is a meeting of the Integrated Risk Committee, which pulls across, as we suggest, from Finance and Performance Committee, our Quality Committee in particular, and takes an integrated view of risk across the risk registers. We've identified some changes. The summary at the end of the paper sets out those risks which have changed, and further detail and further process will continue through that Integrated Risk Committee meetings in the coming month. I'll leave it there, Priya.
Thank you very much. And you've also made very clear that this is a work in progress, in that the strategic objectives are being updated for the year, and the corresponding BAF will follow. So this is potentially our last consideration of the BAF as it currently stands. So thank you.
Absolutely.
For that.
Thank you.
comments and questions in relation to the BAF as it stands and any changes or recommendations to that? And Ilona, please.
Thank you. It was a really helpful cover note. Thanks, Caroline. I'm just wondering for clarification on the two areas of the BAF where we're operating outside our risk appetites. That's the quality and finance one. Could we just pause for a moment and hear a little bit more about the new mitigating actions that have been put in place there, please? Thank you.
I may pull on my colleagues, Rich, Sarah in particular, just in terms of the I would highlight in the finance mitigation, the work that we've seen and had reported to the board around our operational planning and submissions, and the current financial plan work has led to the changes in mitigation in particular. Rich, is there anything you'd want to highlight?
Yeah, thank you. So, I mean, during the course of the year, the last financial year, we, in common, I think, with every system in the NHS in England around November last year, were starting to see financial risk materialise in our reported position. And we took appropriate actions. I guess you describe them as short, medium and long term. Short term involving looking at immediate expenditure commitment controls. So we have some really tight non-pay controls and a ECF, what is it? Recruitment controls in situ within the ICB, and those non-pay controls also feed into what we call the system resourcing group, which is a system-wide quadruple lock, if you like, that for the commitment of new expenditure requires consensus agreement from the ICB, from our partners in FHFT, in BHFT and in SABP. So that's kind of the short-term controls. Medium term, we're really well sighted on the risk in next year's financial plan. It is a long way from being risk-free, but we're really well sighted, and we're doing that in partnership with our colleagues across the system. So a lot of work to do, long way from being risk-free, but we're on that, and we have real grip on it. And then in the longer term, getting into that 2-year financial sustainability piece, we have running into place the allocative efficiency plan. FHFT, in terms of technical efficiency, are doing an awful lot of work on their cost base, on their workforce, on their productivity, which will tie into that. And we have the ongoing conversation with NHS England around the inefficiency driven by the fact that Frimley Park Hospital has RAC, which is an indisputable fact. It does drive inefficiency in the system, and we are taking that conversation forward as well. So there's a range of different financial risk management approaches to cover all of those different things.
Lalitha or Sarah, Lalitha, do you want to come in on the quality risk?
Sarah?
Lalitha, I think it's your risk on inequality, so it's probably better if
It's
you.
the inequalities risk. I think the mitigation would be the core 20+5 work.
So I can go through that. So the stance we've taken is that the core 20+5 needed identification of the population, first of all. So we've identified the core 20, we've identified the plus groups, and I think we presented this last time where we've got people with learning disabilities, carers and adults, and similar tranche in children, including care leavers and so on. We've got the clinical areas within the core 20+5. Many of you have heard of hypertension, SMI, COPD, maternity, and so on. And each of those work streams have an ICS steering group, and the plan is for each of those groups to be mindful of the targets that are set as ambitions within the Core 20+5 program. So, for example, if it's a COPD patient, the recommendation is to increase the uptake of flu, pneumonia, and COVID vaccinations, for example. So we will be working towards increasing the uptake of all of those so that by the time winter hits, for example, admission rates and so on will be lower. We're working not just within the NHS, but also working with our public health partners, local authorities, and so on, in order to make sure that the work that happens on prevention happens within the communities, within our places. And I think that is the mitigation. We've also organized ourselves. We've got within the organizational change program that you've all heard about, we've also got dedicated teams who will be looking at all of this. We're planning to produce a Core 20+5 health inequalities dashboard across the system, so we can actually keep tabs on this and look at it through the ICP, but also the transformation board that we have.
So that's really helpful. Thank you. And Lalitha, would you see us coming? I know the BAF might be changing in the interim because we've refreshed our strategic objectives, but would you see this coming off red and moving to amber later this calendar year? What's the kind of trajectory here, I guess?
I think I would see this coming off perhaps by early next year to March next year, I would say, rather than this year, because I don't know what winter brings.
Understood. Thank you.
Thank you. Really, really helpful. Thank you very much. Right, let's move then to our integrated performance report, and we have Richard Chapman, Sarah Bellas, and Caroline Corrigan taking us into this. So thank you.
Thank you, Chair. Sarah has some slides to share, so I'm going to keep the finance and performance elements fairly brief. So as the board will be aware, we're operating in an extremely challenged environment, both in terms of demand and the available resources to meet that demand. But there are some real achievements to report for the 23-24 financial year. So the draft accounts contained a deficit position for the system of £21.8 million, which is what the system had been forecasting from January. So demonstration of the grip that we talked about earlier and cognizance of our position. Within that, agency spend reduced by approximately 1/3 at FHFT. Again, FHFT working with the system and across the system and delivering in terms of financial improvement and in terms of performance. March waits in ED, so 4-hour wait compliance in the emergency departments. We hit 76% in March, which is not true across much of the country. So a real effort across the system to deliver that. In diagnostics, I referred to this earlier, so now 86% of patients are waiting fewer than 6 weeks, which was below 45% in May last year. And also in primary care, so primary care continues to provide more appointments than it ever previously has, and it's doing so more quickly. So 83% of appointments in February were on the same day. Performance 1 year ago was 77%, and 92% of appointments in primary care were within 14 days in February, where that was 90% 1 year ago. So continued incremental improvement in performance, and I think a real achievement for the system. But I'm going to hand over to Sarah, who is going to talk to us about the quality piece, I think.
Thanks, Rich. Sam, do you have the slides? We've probably just caught you unawares, haven't we, by doing it so quickly? Catch up.
Thank you, Sam. I think we've had a number of slide decks today, so juggling them all is something of a challenge.
It's really difficult, isn't it, Fred?
Yes.
Thanks, Sam. Oh, I'm not sure that's quite the right slide, but carry on, keep going.
Sarah, your voice is a bit quiet.
Okay. I think the front, I don't know what's happened to the front slide. It should say quality one, but please don't worry. It doesn't mean anything. All the rest is fine. So this is a quick overview. We're going to have a look at financial recovery and quality oversight, quality hotspots, quality in an urgent and emergency care, CQC compliance with the system. We've got a little update on the Hilary Cass report, and we've popped in 3 extra slides about the infected blood inquiry. We use the National Quality Board guidance on risk response and escalation in the system. If you want to go to the next slide, please, Sam.
Sarah, can we just check that we can all hear? Can we all hear Sarah now?
Yeah.
You want me to, if I get any
Yes,
closer
yes.
to the screen, you'll get my face full on. I'm struggling to get any closer. Okay, so I just wanted to give a quick update on the PSERF, or the Patient Safety Incident Response Framework. This is the new way of looking and responding to safety incidents within the NHS that we have been implementing this year across all providers. And we've been working with our providers to do that. Fundamentally, responses to incidents will be prompted by the level of harm, and will no longer be prompted by the level of harm. They'll instead be proportionate to the learning potential. And the rationale for this was we were spending a lot of time investigating things where the learning was very apparent at the beginning, and actually it's better to be putting in place the implementation of that learning and preventing future incidents, rather than keep doing long drawn out investigations where the learning is apparent. If we move on to the next slide, please, and we look at quality hotspots. One of the things I wanted to raise was neurodiversity. This is an area that keeps coming up. We have a risk on our risk registers that's escalated up through the quality route, which the board will have seen through the quality escalations report. That means that people are waiting for long waits, and this remains in an area that we are keeping a close eye on. We're taking deep dive reviews to ensure there's no harm for those on the waiting list, and we're looking at how we can do things differently in order to support people. We've agreed additional funding to support assessments in North East Hants and Farnham, where there was a gap in provision, and that was a key area for us. So if we move on to the next slide. We're working very hard on looking at our out of area placements for vulnerable people placed out of areas, and working with our local authorities where there have been concerns, and there have been some particular concerns in some areas, and we continue to look at where further placements are, and we do it with the person and their family. But it has been an area that we've had a great degree of focus on, because we recognise the vulnerability of the individuals. We go to the next slide, please. The MHRA issued a safety alert, and the reason I bring this to you, they released it in August 23, and there were 7 key actions in this safety alert that providers had to be compliant with by the 1st of March 24. Whilst we were reviewing the alert between August and January, we recognised that it was a really big piece of work, and that we wouldn't be able to be compliant with it in its entirety by the 1st of March. The reason is that pieces of equipment have been given out for numbers of years. These include bed rails, bars where you can pull yourself up in the bed, and other small pieces of equipment that require risk assessment and review, and there are thousands and thousands of pieces of this equipment. It's not something that we're going to be able to do overnight. We're working with NHS England at a regional level, and they're working at a national level to look at a solution, and our assistant director for AHPs, and I'm trying to think, I can't think of the word for the acronym for AHPs. It will come to me in a minute. Sorry, I do apologise. Hopefully somebody else will put it in the chat for us. Is working on this with NHS England to try and address it. but we've looked at it from a risk perspective and are targeting the higher risks associated with this. And we're continuing to work on mitigating this. Thank you, Lolita. Allied healthcare professionals had a moment where my brain wasn't working. Can we move on to the next slide? So this gives us an overview of CQC and compliance across the geography. As you can see, we have BHFT that are an outstanding organisation. Our other organisations that we directly work with are good. Our 2 ambulance providers, whilst they're currently rated as inadequate, actually there are oversight groups which are led by other systems that we are a part of, and both services have made huge progress against this and have addressed the quality and safety concerns that were identified in the original reports. Can we move to the next slide? So the publication of the CAS report, Dr. Hilary Cass submitted her final report and recommendations to NHS England in her role as chair of the independent review of gender identity services for children and young people. Their review was commissioned by NHS England to make recommendations on how to improve gender identity services and ensure that children and young people who are questioning their gender identity or experience gender dysphoria receive a high standard of care that meets their needs, is safe, holistic and effective. They've published the findings, and I've listed the findings there and there in the report. I'm not going to go through them. I think the important thing is for us to look at the next slide to see what we've been doing locally. So before the final report was published and when there was an interim review, we'd worked across our system to try and implement some things that were important at the time and were obvious. And we were implementing support to young people transferring between services. We've worked with primary care and helping them to support them to have discussion with young people who wish to be referred to adult services due to age and wait times, because there were exceptionally long wait times in the children's services. We've been educating key clinicians and staff groups on how to support, and we've been looking at local pathways for holistic assessment. We have clear policy and procedures regarding prescribing of gender suppressing hormones for our clinicians within primary care. Rachel.
Just wanted to request, if possible, that some materials or information sessions are arranged for schools and for social care, because for a lot of young people who may be gender questioning, the first place where that will be noted, identified, and the initial support put in will be either in schools or social care settings, and so it'd be helpful for them to have a better understanding of how the policy response is being taken forward.
Absolutely, Rachel. We're really delighted to do that. I think we've been focusing on upskilling key clinicians at the moment because there is a cohort of children that we actually need to approach proactively. But I will ask Tracy Faraday-Drake and the Children's Board, which I think you're the chair of, to take that as an agenda item for consideration to see how we can do that, because I think you're absolutely right. We need to be looking at that wider impact and thinking about where children, young people get their support and their pastoral care from in those early stages. And you're right, school is a very key area. Okay, thank you. Can we move on to the next slide? So the obviously this is all very new, and the final publication, well, it's new and it's not new. The final publication happened yesterday around the infected blood inquiry. And I think the first thing we'd want to say, and I know that our Chief Exec has already reflected on this, is that we would like to express our most sincere sympathies to everyone who received infected blood products within the NHS Frimley geography between the 1970s and the early 1990s. And we absolutely acknowledge, but those patients, this was catastrophic and had devastating consequences, not only for the patients, but their families and their loved ones. And we are extremely sorry that this happened, and for any instances where patients did not receive the level of care they rightly expected. I'm sorry I read that, but I read it because I wanted to make sure I got it right, but it was the words that I'd written earlier. Can we move on to the next slide? So NHSE have published their initial steps and the things that we will be supporting them to take. They are looking at support for those affected and have made available significant funds for services for those people, and we will work with them to implement anything that we're expected to do. Supporting affected staff, continuing to find and treat people with bloodborne viruses, ensuring that patients can access the right information, and maintaining confidence in current blood and blood products and related treatments. And if we go to the final slide. So really wanted to press the safety of current blood and blood products, and that we know that many people will be concerned about their own health following the media coverage. So the NHS has set up a new online resource for patients and the public to find help and support, and we've included the link. I also wanted to say that since 1991, all blood donated in the UK is screened and distributed by the NHS Blood and Transport, following rigorous safety standards and testing to protect both donors and patients. And since testing has been introduced, the risk of getting an infection from a blood transfusion or product is very low. All blood donors are screened at every donation, and every donation is tested before it's sent to hospital. Blood services and blood safety has been transformed, not only in terms of technical advances, but in testing, but also in the way donors are recruited and checked and are safe to donate. And it's really important that that message is shared, because, you know, when people need blood and blood products, it's for a reason, and we don't need people to feel frightened or worried about receiving them. Thank you. I'm sorry, Priya, that I've gone over, but I really wanted to say those things properly and make sure that they were clear.
Very helpful to have done so, Sarah. This is a time when people will be reflecting on exactly that, the safety of blood products, and that is a good assurance to be giving. So thank you for that. Colleagues, board colleagues, any comments or questions in relation to any part of the integrated performance report? Safina, please.
Thanks, Chair. Just on the CAST report, Sarah, I think we saw government guidance in schools as well, and in terms of not to kind of teach gender identity. So I thought just a comment around making sure that the trans young people and children are central to all them conversations, really, and making sure their mental health and well-being is you know, at the forefront. I know that's happening, but I think with the report last week around gender identity and then the CAST report, really important that we keep that focus on the trans young people and engage with our local trans population as well.
Thanks, Safina. And I think that you know, that's why we've tried to be really thoughtful and educate our staff so that people can have good conversations, because I think there's nothing worse than trying to seek a conversation from a trusted healthcare professional and not receive a good dialogue.
Thank you, and thank you all. We don't have any questions from the public today. I know that our agenda reflects those things that the public have indicated to us are of interest and importance. From board colleagues, any other business? Seeing shakes of the head, so it remains for me to say thank you to board colleagues, all presenters, to the Mirror board members who have joined us and contributed as well today, to members of the public who have joined, and a big thank you to Sam Branscombe, who has guided our slides today, having had the largest pack of slides ever. So thank you very much, Sam. Take care, everybody.
Thanks. Bye, everyone.
Thank you.